Good morning, everybody. Thank you so much for joining me this beautiful Thursday morning. Today, I have my great friend Terry Fletcher with me.
Good
Uh,
morning.
Terry, thanks so much for coming on the show today. I really appreciate it.
Thanks for having me. I'm glad to be here.
Terry and we got to hang out a couple of weeks ago when I was out in California. And she is just as amazing in person
Oh,
as she
geez.
is on the webinars. And as we see her virtually, she is even better in
Oh,
person.
you're
So
cute. Well, my husband thought you were funny. He's like, okay, I've seen your twin. What do they call it? Your shadow animal or something. He's
that's
like,
right.
I see your twin, your alter ego. I'm like, yeah, we could chat about healthcare forever. And I go, and we like it. We're not saying we're talking shop. This is our conversation.
Absolutely. I couldn't agree with you more. It's so nice when we do get to talk with our friends about what makes us, what drives us, our passions,
It
and
is.
some of the struggles. It's great to have someone to bounce things off. I was telling my class last night. I was just finishing up a billing class last night, and I told them that the greatest asset that you have in this industry is your network. And it doesn't matter how many years of experience you have, sometimes you hear something a little wonky and you need to run it by your colleagues and go, this is just wonky enough that I got to stop and ask this question. And it doesn't make us less of an expert or as a someone strong in our profession. It just means that we take that extra step to make sure that
Yes.
what we're saying is right.
Well, and I think also, I think people forget sometimes the isolation of consultants. Independent consultants, we get to see you and talk to you. A lot of times it's virtual now. But we're not sitting in an office like you are where you can just turn around and go, hey, I have a question on this. Can you help out? Or, so we texting is awesome. I even texted you yesterday saying, I know the answer to this, but I got a mobile unit place of service question. And luckily you were available to respond right back. But
Yeah,
it's interesting. Yeah, I think that it's just so nice that we have this network, and thank God for LinkedIn, and that we've met, and we have people that we can bounce things off of, because it is a lonely life sometimes being an independent consultant.
it is. It absolutely is. And you have nobody to share news with, like it's National Orange Juice Day, Terry.
Oh no. Oh no. Oh
Or
no.
or here's a better one. May the 4th be with you.
Oh geez.
Okay.
Yes.
Okay,
Yes.
last one. Tomorrow, Cinco de Mayo.
Okay. Yes. That
Okay.
one's good.
Okay,
Just
thanks.
an
Thanks.
excuse for
I
my
tried.
margaritas. Okay. Good.
Well, thanks for coming on today. We're going to continue to dive down the ICD-10 guidelines. And I always share this with my friends. I'm very aware that the guidelines are like IKEA furniture assembly instructions.
Yes.
And it's tough. So sometimes it's great to get different perspectives, and who better than the cardiology guru, my friend Terry Fletcher.
Well, we'll see, I guess, because it's like, oh yeah, what is Christy and I talking about? Oh yeah, let me go like brush up on my skills there. I was like, because you do it every day, but the little nuances sometimes that are actually in the coding guidelines, or
Mm-hmm.
some of the little languages and the parentheses and the parentheticals and the quotes they put in. We sometimes, I don't want to say take it for granted, but you just want to get brush up on the actual wording that they have. Sometimes we're like, oh yeah, I forgot they said that.
Well, I think it's good to review the guidelines once a year. And
Yeah,
and and I'm going to be the first one to tell you it's a struggle.
it
It
is.
it it has to be scheduled. I have to set the time aside. I have to psych myself out. But every time I read it, there's something between the beginning and the end that turns me on. Oh my gosh, I didn't realize the answer was right here all the time. Um, because, like you said, we get so in the groove of doing the same thing over and over again that we kind of miss the idea um, that we have these guidelines to help us out.
We
And
do, and I actually get excited when the new CPT books come out, which is getting earlier and earlier. ICD-10, not so much. I mean, I know we get it more virtually. We don't really get, I still get a paper book on CPT, but because I need to have one on my desk every minute. When
mm-hmm,
they stop
mm-hmm.
doing the paper, I'm going to be in trouble. But the ICD-10 is. first of all, we get the general guidelines, so the official
Hmm.
guidelines, and then we get the codes. And I actually don't think, Christine, a lot of people know there are two different things.
Yeah.
One is directions and what the expectation is on how to use them, and the other ones are the actual codes, and then how those codes are used within the codes. And I hope that kind of makes sense. But I see a lot of people sometimes when I reference the general guidelines, they're like, what's that? Is that the beginning? I'm like, oh, okay. Yeah.
No, you're absolutely right. And think when so the first people to publish the new guidelines, codes, instructions is the CDC.
Yeah.
And they always have this real unique way of separating out alpha index, tabular notes, and then the changes within the tabular notes. Because one thing that I think, and I know this is just again talking generally, one thing I don't think everybody remembers is that those changes come to the tabular instructions as well. They may add an includes, they may add an excludes one or two, they might add a code first that wasn't there the year before.
Right.
So the review really needs to be a little bit of a deep dive review to see exactly how it impacts your particular industry, especially value-based reimbursement.
Yes, and that's actually becoming more and more of a conversation. I actually listened to a webinar recently on value based. And honestly, I don't understand how it's positive for the physician, because overall it's going to mean lower reimbursement, but better access to everything for the patient. But
Mhm.
then as I'm listening to it, and I realize that, oh, Medicare is eventually going to go to the ACO, MCO type outline, I guess, model's the word.
Mhm.
And so now I see where the value-based care is coming. And so, yeah, we have to really kind of tighten up these guidelines.
For sure, for sure. So, couple of other things. We had 43 new codes this year that were added to the cardiology section, mostly around atherosclerosis, different types of tachycardia, conditions of the aorta. I don't know about you, but the aorta is a pet peeve of mine. I
Yes.
when I see an unspecified aorta, I think to myself, it's massive. The aorta starts like way up here. How can you say, and it goes way down there? And how can you say the aorta?
Well, and I don't like the unspecified lower extremities when you're dealing with, vascular things. I'm just like, you didn't pay attention what leg it was. I mean, to me, that's just lazy coding. At least put right or left. I mean, give us something.
Right?
So
Well, it goes
yeah,
back to the GEMS mapping. And
yeah,
of course, now that we are all these years into ICD-10, why we still rely on the GEMS mapping, and that's the general equivalency mapping. So when we changed from 9 to 10, a lot of doctors said, "Hey, just give me the crosswalk. Whatever it was in 9, tell me what it is in 10."
and there wasn't
And
a direct crosswalk.
not when you go from 17,000 codes to 70,000 codes. I
Yeah,
mean, the
no.
math just doesn't add up.
It doesn't. It's like when people say, "Well, just give me the crosswalk when they took away consults," and said, in Medicare, and said, "Just give me the crosswalk to either the new patient or the hospital codes." I'm like, "Well, it doesn't work that way."
Right.
So there's a little difference, nuanced when you look at it. So, but before we get started in actual coding, and you and I talked about this off camera to
Mhm.
start. I think we need to bring up the statement that was added to the general
Yes.
guidelines, and I think this is really good for those of you that are primarily in ICD-10, or this is kind of where you work the most, and you're in CDI, so clinical documentation. You can either call it improvement or integrity. Either one works for us.
Mhm.
But when you're dealing with that, here's a statement that came out under the Section 1B Coding Guidelines 18, and this is before the codes. It said that, and this is in the introductory section of the official coding guidelines. A joint effort between the healthcare provider and the coder is essential to achieve complete and accurate documentation, code assignment, and reporting of diagnoses and procedures. The importance of consistent, complete documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved, and the entire record should be reviewed to determine the specific reason for the encounter and the conditions treated. What I really like this is it said the joint effort between the healthcare provider and the coder. Christine, they've never said that before. They finally recognized coders as someone that has to be part of that collaborative effort.
Absolutely. I
So
couldn't agree more. And I thought that that was a brilliant statement. I thought that that was something that every coder needs to have printed on their desk. Like that
tell
should
the
be their
people that
mantra
afford it.
behind their desk. Like, let's work together. I know that's what we've been saying, but now it's in writing.
It's in
They
writing.
they saw the importance of, and when I say they, I mean all the collaborative agencies saw the importance of making sure that was in writing in the guidelines there. And I couldn't say thank you enough to all of those collaborating agencies for making sure that they included that relationship there. There's more and more discussion about queries in the guidelines now, more than we'd ever had before. So if anything is conflicting, query. And they are encouraging the query. So providers should see that as well. Like we're not always there to bug or bother or chase down. It's that we need additional information to really show that specificity in diagnosis. And if I can jump on one more little bandwagon that's again off topic, but not really, modifier 25 is the date is coming closer and closer that Cigna has shared with us. And although a lot of organizations are on top of this, the beautiful letter that the AMA wrote, um, uh, um, for those of you that don't know, Cigna put out a letter that said that effective on the 23rd of this month, they're going to start requiring documentation for all claims that are submitted with a modifier 25. Where my mind immediately went was when I look at modifier 25 and it says separately significant, separately identifiable.
Yes.
I always thought, well, even if it was the same condition that we're treating and it says it doesn't have to have a separate diagnosis. What if that diagnosis, though, was specific enough to include a new manifestation that made that a significant separate visit? Or what if the diagnosis, those use an additional code to explain other or to explain a comorbidity that we needed to treat? What if that diagnosis was so specific that the diagnosis made it easy to see the support of modifier 25?
Right. No, I agree. And I think that the CPT direction saying you don't need a different diagnosis doesn't help us billers out there, you know? It's just like, well, then how do you show that it's a significant separate service?
Right.
And, I think that that whole thing is really because of bad actors. You have a patient who's scheduled for a procedure, so a lipoma removal or an endoscopy or an injection or something that is pre-scheduled.
Mm-hmm.
And the patient walks in and they say, hi, how are you doing, to the doctor? And they say, okay, we're going to do your injection now. And they try to also bill for an E&M service. That's why this whole thing
Yeah.
came up. And
I
it's
was
like,
talking to a
uh,
friend of ours who's on here today. Hey, Betty, yesterday. And, she was telling me that there was, that she had talked with somebody who developed a unique program that would add an additional visit in between the decision to make surgery and the surgical date. And that was with a PA or an NP to look for risk factors for the surgery. And the first thing that I thought was, well, when the doctor made the decision for surgery, did they not have the
yeah,
capability of identifying risk factors? Did they really need to hire a PA or an NP to come in behind them and go, hey, doc, you forgot this? I mean, sometimes
yeah.
it doesn't make sense to us when we're thinking about those things, right?
Yeah, I've
And I
actually
might be
had
saying it wrong.
no,
Betty,
you're saying it right.
okay.
Yeah, no, it's funny though because I see doctors have been emailing me ever since that announcement was made, and practices and saying, so we've decided how we're going to handle it is that we're just going to bill the procedure on a different date. I'm like, wait, what? Wait, okay, what? And they said, so we're going to continue to do the, how we do it, but we're just going to split the date. I said, so patient comes in the office, they're going to get a minor procedure, they're going to have an office visit with a 25 modifier. And then I said, but you changed it. You're going to take off the modifier. And then the day after, when the patients and they are flying to Europe on vacation, you're going to say they were actually there getting their injection. They're like, oh, I was like, yeah,
Right?
and or the preventative visit, that we don't really call them split visits, but we basically the preventative with the office visit. We've
Yeah.
got, ICD-10 issues with that. We've got 25 modifier issues with that. So, that aside, I know we're getting off on a tangent here,
No,
but
no, but I think it's a
it's
good topic to talk about because again, I don't know that providers really understand that the diagnosis really helps drive billing purposes. When you just said those preventive visits with an office visit on the same day and they share the same diagnosis codes.
yeah,
Well, what was significant and separate between these
separate.
two? Because they mirror each other so much. Was it because you opened up a separate encounter and you copied all of this and you dropped it onto another encounter and now we're calling that two separate encounters? It wasn't a separate encounter. Or I had a doctor recently said, so what you're telling me, Christine, is that I need to see the patient, reschedule them for another day to have the procedure. So now they have to come in twice. And I think, why would you see them in between if you saw them and said, if it doesn't get better, I'm going to do this. And then you bring them back in to do this. Why do you need a third visit?
Yeah,
Where is that?
exactly.
So I said, I don't know, doc, of course you would have to make the decision. Is it medically necessary to assess it and then have them come in to assess it again and then have them come in to assess it again before you do what you originally said in the first visit?
Yeah, I talk to doctors about that all the time. I said, well, what is it that you're doing extra when you've already pre-scheduled them to come in for that procedure? And they said, well, I have to reassess them. I'm like, why? Did they have a new complaint that you're having to address? Let's just go back to basics.
Did
They're
it
like,
change
no.
so much that it required you to stop and look at it again to make a decision? Now, it could be, Terry. So I don't know if I shared this with you, but my husband, when he came out to California, he had an infection in his knee. It was a nasty
Oh,
infection. And so when he got home, he went to his primary care, or not his primary care, his orthopedic doctor, who again said, I'm on the fence. And he wrote it in his note. I'm on the fence. I don't know if I need to go in and do an IND. Right now, we're going to monitor it. About I want you to come back in a couple of days. They put lines on his leg, and there was a true reassessment
yeah.
on that second day where we saw the regression of infection was documented. The success of the antibiotics was documented. And I could see that it was getting better in the notes that his provider was documenting. So we could easily see that. It's just when the notes don't provide that information that it gets complicated.
It does, which actually is a good segue into coding for cardiology and cardiovascular diagnoses. I see what you did there.
So I don't know about you, but I like that very first paragraph in the guidelines where they tell us as coders. It's one of the very few places in the guidelines where coders get empowered. I read that primary paragraph there and I always do like it says we are allowed to assume. You may presume that there's a causal relationship. Oh, I can? Thanks. So when
Actually,
they're
let me interrupt you real quick. You just said the word causal. So for anybody who's watching, listening, it's not casual. I had a doctor reiterate that to me. He goes, well, let's look at this. He goes, it says a casual relationship. I go, no, read the word again. He goes, oh, shoot. I'm like, it's causal, meaning there's a relationship that's tied together somewhere and intersect. And he's like, I've been looking at that as casual the whole time. I'm sorry, I could not stop laughing.
No, but
So.
that's so true. And it does make a difference. And I'm sure that provider now is turned into your like number one
He
documenter.
is. He's pretty funny.
But this paragraph tells us that unless there is documentation saying against it, like, okay, no, absolutely not. Their kidney disease is not related at all to their hypertension, or their heart disease is not related to their hypertension. But otherwise, that's the one area that I think it's the one and only area that I can stand by those providers when they say, when I say this, I mean this. Okay, you're supported in the guidelines. I can run with that one. That's
Yeah,
the only place
I
that I
can
can
too.
run with it, though.
Yeah, that one will end COVID. COVID's got
Right,
some
right,
things there
right.
too where they can let you make some assumptions, which I don't like, but we won't go there. But I think when we get into some of the relationship between hypertension, for example, and heart involvement between hypertension and kidney involvement and hypertension, all this heart disease.
Hmm.
They do make the assumption, and I guess that with the causal relationship, they make the presumption. How about that?
Yes.
That there is a causal relationship between the two conditions. What's interesting, though, Christine, is that they seem to want, and I'm saying they, the powers that be that create these
Hmm.
guidelines, they seem to want the language to be specific, where the doctors have said with, so hypertension with kidney disease, hypertension with, when they look at this, with kidney involvement, et cetera. And I'm not always seeing the physicians living up to the language direction. I don't know about you. And
No.
so for me, I feel like cardiology is a place where I do a lot more query, because even though it does allow us to presume that relationship,
Hmm.
it makes
Hmm.
me nervous to do that, especially somebody with, let's say, chronic kidney disease,
Right.
or somebody with renal failure. I'm really concerned about doing that without the doctor specifying it in the note. I don't know about you.
No, no, I agree with you because there are more than just hypertension as the cause of renal failure or the cause of renal conditions. And same thing with heart failure. Hypertension is not always the catalyst. And I know that. I've had a friend of mine who had congestive heart failure secondary to radiation for breast cancer, which so none of that had to do with any type of hypertension. She did eventually get hypertensive from the pain from the conditions that she had. But so, although this guidance falls in there, you're 100% right. We're not 100% sure that that's what it's related to. Another one, I had a young lady who had a congenital kidney disease. And because of that, she became very obese, and the obesity caused hypertension. But it wasn't the kidney disease. She'd had that way before that hypertension had kicked in, and it was easy to make that relationship with the obesity for her. So you're right. We still need to talk to our cardiologists, even our primary cares who might be managing these conditions, and remind them that we need that with and due to because of
Yeah,
related to.
we do. Well, and I was sitting down with a group of physicians, cardiologists, about this. And one of the physicians, which I thought she brought up a really, really good point, and she was a newer physician. She said, well, I'm not necessarily reading that as you're making that presumptive causal relationship because there's an actual kidney condition. It says kidney or involvement. And
Mhm.
so, or heart involvement to the hypertension, for example. And she goes, involvement to me means that it's tied together, but it doesn't necessarily mean that there is a chronic condition that helped manifest it. And I was like, okay, now you just added another layer to
Right,
this
right.
question, because they do use the word involvement. So under,
True.
under the first part of that chapter 9. And so I guess some of it is really what the physician thinks of in their thought process with the language, and then what a coder would pull from it in their thought process with the language. And that's why I think, again, going back to that collaborative statement, it's really working together to figure out what does the patient have without overcoding
Mhm.
or undercoding, but making sure it's correct coding. And I still think there's that gray area sometimes, especially in the cardiovascular area or circulatory area.
I It's funny that you mentioned that. I just had a conversation earlier this morning with a physician practice, and they were asking about how they can make some improvements in their documentation. And what I recommended was go and do a productivity report on the top 10 diagnoses that you've seen this year or within the last 12 months. And then sit down with the physician, have like a little round table with the physician. What are the top questions that help you in the management of these conditions? So, does the patient monitor it at home? Are there any other related signs and symptoms that we can tie together? Let's start getting away from just those boxes that were created in the EMR to help us with 95, 97 guidelines. Why don't we really have that roundtable with physicians where they share with coders, medical assistants? When I say this, I mean this. And then coders can say, but that's not enough. I need this. Great. Then we can modify that. Medical assistant, ask them this and this question when it comes to these conditions. Like, make a team effort to really involve the key players that contribute to the medical record, and then assign the appropriate codes relating to that medical record.
I agree. And I think one of the harder areas to code is hypertensive chronic kidney disease.
Yeah.
And the reason I say that is because it says that you're in the I-12 category, but
Mm-hmm.
it says when both hypertension and a condition classifiable to the category N18, which is chronic kidney disease, that's present. It says the chronic kidney disease should not be coded as hypertensive if the provider indicates that the CKD isn't related to the hypertension. So now they're saying they not only have to put in things that are related, but now we have to have it clearly written in the documentation that it
Yep.
isn't related. I don't see doctors doing that. Does anybody else? I mean, I see we have a lot of comments on this, and I'm not seeing physicians telling us what's not related. It's hard enough to get them to tell us there's a
I know, right?
causal relationship between the two. But and then it says the appropriate code from the N18 category should also be used as a secondary diagnosis because they want to know the stage of
Right.
the chronic kidney disease. So there's a lot of moving pieces when it comes to not just the circulatory system, but the doctors, I think they want the coders to absolutely just kind of know this information and be basically say, just put it in. You know, it's fine. Just put it in. If I say it's this or that, just put it in the system. And I think that can be dangerous, especially with how insurance coverages are right now. Um, we see, I think you and I see all the time, and I know
Mm-hmm.
that our listeners see this, is the OIG and HHS are constantly getting on Medicare Advantage plans for upcoding HCCs.
Yep.
And these are right in those hierarchy codes. So, I don't see the physicians usually will, and this is just what I see. The
Yeah.
physicians will usually give us the patient has um, chronic kidney disease or an acute disease or something related to the chronic kidney or renal or whatever, and then they'll give us hypertension in that stage. They don't actually. Don't remember the last time I saw a relationship tie.
I know.
I don't
I
remember
I
seeing
agree
it.
with you. I
Yeah.
agree with you so much. Um, And I wanted to talk about two more things before we conclude. One of them is um, when we talk about hypertension and heart disease, they specifically tell us what series of heart failure codes qualify as that relationship with hypertension to get that I-11 codes. So we got to make sure that we're looking at heart diseases that fit in the heart failure category.
Right.
And they're very specific about that. So recently I had another office call me and they said, well, Christine, it's like hypertension in any heart disease. Well, the patient has arteriosclerosis. That's not what they're talking about. They're very specific about that. And the other thing is to remind people that um, elevated blood pressure is not hypertension. Elevated blood pressure is just elevated blood pressure.
Right.
And that's the information that we need to make sure is coded correctly. We should never assume. Uh, I mean, I would be very concerned if someone had 210 over 110, right? But I, as a coder, can never make that determination that that is hypertension. That's
Right. And then
respectfully, I have to query.
I think that this is where it also wraps back to the E&M, where the new code, the new guidelines, where we're trying to get the physicians to give us their thought process,
Yeah.
not just with the ICD-10, but also within the note of the E&M service. And when
Mhm.
you can't, they all tie together. And when you can't get more documentation than just HTN or DM for diabetes or, MI, I mean, give us more information. Otherwise, we're not only going to keep querying you, there's some presumptions made, especially in tying in, that we're allowed to do that. And we don't always want to be responsible for that.
I love that you mentioned MI. Um,
Yeah.
Recently, I did a little research project with OIG work plans. And in the last 3 years, OIG has audited and reported on 13 Medicare Advantage programs and their selection of diagnosis codes. And every single Medicare Advantage plan had errors in the MI situation. So they were all reporting acute MIs in the office. Now, I don't know about you, but I have never received a phone call that said, hey, can I get an appointment for 3 weeks from now? Because I'm going to have an MI and I just rather do it there at the office, right? But I know, but we see that a lot, that the patient
We
has
do.
had an acute MI and we're thinking this was a scheduled follow-up appointment. And when did this MI happen? Oh, 6 years ago. Okay, my bad. Sorry. Right.
Old am I? Yeah, exactly. Well, it's also tied to the interventions. So the 99241, which is to 92941, sorry, 92941, which is the acute MI stent or intervention. Well, it says in there during an acute MI. Well, everybody wants to code that for non-STEMI and STEMI. So STEMI when it's going like this,
Right.
non-STEMI when you means you probably had one, and there's something called acute coronary syndrome. But if you're not in the throes of an acute myocardial infarction, then you're not using that code.
Right.
Because, that's not, and even CPT Assisted came out and said it has to be emergent in nature. It can't be that within the last 24, 48 hours, you happen to have an MI, because you may have, but it's calmed down at this point. But I get that a lot where people are trying to code an acute MI when it's actually acute coronary syndrome or non-STEMI, and it doesn't tie into the 92941 intervention code. So definitely.
It's funny that you mentioned that, because there's a guideline for that too.
There is.
So I think to wrap all of this up, it's time that we make time to review these guidelines again. And maybe review them in small chunks. Maybe tonight you only look at chapter 9 in section 1, subsection C, and you just go through. I love to paraphrase next to it. There's a lot of room next to the guideline, and I love to go in and paraphrase. Number 1 code should be this. Number 2 code should be this, or highlight certain words that mean something within 4 weeks. Those key things that really assist us in finding that. Not that we're ever going to memorize these guidelines, God forbid, but it leaves a little breadcrumb in your mind of, oh, I remember there's something in the guideline about hypertension or MI or right. And that will direct you back during those times where you are coding.
And also when you're doing your, like Christine said, when you're taking your notes and highlighting your sections, also have another note or a section that says, oh, and when this happens. So perfect example, when you've got a type 1, non-STEMI that evolves to a STEMI, it can, right in that encounter. But then it's calmed down or it converts to a non-STEMI because the doctor gave him some thrombolytic therapy. That's still reported as a STEMI because during that encounter it was STEMI. So, but I think that's sometimes missed. And just a little note, please do not call them cheat sheets. They are reference tools. Do not call them cheat sheets. If you ever have to go against an arbiter or you have to be in any kind of legal, scenario, they're going to say, who are you trying to cheat? Do not call them cheat sheets. I've been in front of enough attorneys on both the payer and the physician side, and that's the first thing they get on people is like, let me see your cheat sheets, and they start to pull them out. I'm like, oh, face plant. I'm like, no, these are reference guides. Please don't do that.
Go through all of them today and cross off cheat and put in reference.
It's a reference tool. Everything's a tool,
That's right.
So just
great advice, Terry. Thanks so much. Thanks for taking the time. I can't believe it's over already, but thanks for taking the time today. If you have any questions about cardiology, coding, billing, reimbursement, Carrie is the guru. Reach out to her. Her information is there on the bottom. She is a wealth of knowledge. She has an amazing membership subscription. If you're not already subscribed, you need to subscribe today. Priceless information there. And I guess we'll see you in 2 weeks. Happy Cinco de Mayo to everyone. And thanks so much, Terry.
Thank you.
Thanks for watching.